Okay, fever is sympathetic system that kicking in, and then you get sinus tachy. Okay.
We're going to be septic.
What would be the symptom? Septic, but what caused the septic patient have sinus tachy?
Because the
What's the main
vascular
cause?
system's expanding due to the fact that the poison in the blood and it's fluid loss.
Fluid loss. That's a key word there. You know, the dehydration is the one. Not the septic that caused your tachycardia, but the dehydration, the fluid loss, you know, the fluid shift. That's what caused the tachycardic. So, you know, 99% of the time is about fluid loss. So when you are having patients who have tachycardia, you do have to think about dehydration would be number one. So, you know, but the dehydration, what's the common cause of dehydration? Besides, you're not eating, drinking enough.
Fluid space.
Diuretics, okay. Sometimes diuretics cause dehydration.
Is it third spacing?
Huh? Third spacings, okay. Some patients, they do have fluid shift in a different place.
We have antibiotics.
Yeah, that's third spacing. Okay, you have active fluid loss by vomiting and diarrhea.
Trauma.
Burns.
Well, what does trauma do?
No, blood loss.
Blood loss, okay? So you got to think about, you know, don't think about the disease in the term, but you got to think what's a specific, more specific cause that, you know, this patient would have tachycardia, okay? Usually the tachycardia is all about fluid loss. And then, you know, you got to say, okay, what kind of fluids am I going to replace with this patient? Again, you go back and look at the cost. If you're having blood loss, you replace the blood. If you are having dehydration by active loss, that's a very key thing that you have to understand. Active loss, like you say, vomiting, diarrhea. What do you have to treat first?
Vomiting, diarrhea.
You got to treat the vomiting and diarrhea. Don't get pumping fluid in there and not treating the diarrhea vomiting.
It goes out. Chasing your tail.
Yeah, you keep. And I see doctors doing that too. I'm like, okay, you know, it's not working. So, very important, yeah. And then, you know, especially a patient who has GI bleed, right? Got to get that blood to replace. But the thing is, yes, I will pump those blood into there, but what do you have to do on the other side?
Stop the bleeding.
You got to take this patient to the EGD and stop this bleeding, right? You know, a lot of my GI doctors said, well, I'm not gonna take him to EGD until you get her hemoglobin up to 9. I'm like, well, how am I gonna do that? It's just one end out and the other end circling. So it's not gonna happen. You have to collaborate with each other. So that's why always have to go back, what the cause, and treat the cause, right? If you have a fever, then of course you have to treat the fever, right? Oh wait, I'm not done there yet. So now we determined the cause, and then we said, okay, we look. There's no fever, there's no blood loss, there's no dehydration, and sometimes what would be other things that may cause tachycardia? Anxiety, definitely. As I walk in here, I did have tachycardia. Cindy said, "You okay?" I'm not really. Yeah, you're right. You know, you do have tachycardia with anxiety. You know, especially with patient again. You know, you do have to treat that anxiety. You know, a lot of times, you know, you keep giving all these medication and you're not looking at the anxiety. And then once the patient totally mellow out, guess what? You bother them down. So that's why you do have to go back and look at the anxiety as another factor. Okay? So let's say you do all this, and then what would be an ideal drug if we have tachycardia that we will be treating? If we come to think about drugs. We're talking about that earlier a lot. We use beta blocker would always be our first drug of choice, right? To slowing it down, and you know, because beta blocker is not only slowing it down, but it's also improve the contractility. So that's why it's always our first drug of choice. What would be our next drug?
Antiarrhythmic, some sort.
But if you have sinus tachy, we would not go to antidyspeptias drug.
Just fluids.
Sometimes we do digoxin. The problem with digoxin is that, you know, it takes a long time to work. It takes like at least 3 to 6 hours to slow it down.
Do you leave a fit? Vasopressor?
We're not going that far yet because patients do okay. Well, think about other pharmacology Go back to your pharmacology class. Think about what stimulates the heart to pump. Calcium channel blocker, right? You have to have calcium in order to do that. So you have to give calcium channel blocker. That will blocking the calcium, and then it will slow down a little bit. Very good. So that's what we would think about calcium channel blocker. What's the what kind of drug that you could think about calcium channel blocker? Diethyazem, right? Cardiology, diethyazem, right? So I think the drug start with
Where?
huh? So yeah, I would give calcium channel blocker. That's very common too. That they give cardiology drip, right, to slow down the heart rate. And then a lot of times the nurses say, well, the patient. Think about it. When you have tachycardic, is the heart pump effectively? No. So you get hypotensive or hypertensive? Hypo, right? So a lot of time, as a new nurse, I did the same thing. The doctor said, go ahead and give the Cardizem, the diethyazem. The problem is the calcium channel blocker, it not only slow down your heart rate, it's also drop your blood pressure, right? I said, but wait a minute, his heart rate is 150 with a blood pressure of 80. Should I really giving it? What do you guys think?
No.
Yes. Why? Because you slow down the heart rate, you increase the filling pressures, and you will pump more effectively. You have to look at me funny. Hey, I got it. So that's why the thing is that, I wouldn't start really fast. Like usually Cardizem drip, they start like about 10 to 20, but I would start with 10 and I titrate. You're right.
Yes, sir. Where do you go to the point where, what's the rate? This saying 107, okay, when it's 190, 100 to 200 to 250, where do you go from that point? What you use when you get to the 200 levels? It's not atropine, there's another one that they give. It's just
Rapamil. I mean, not adenosine.
Adenosine.
Yeah.
And that's
when the patient really have a symptom, right? That's when the patient really has symptoms. They become what do you call altered LOC. They start to have tachycardic. They have tachypnea, blood pressure like in the toilet. I would definitely, even before adenosine, I would probably cardiovert them. But it's funny because any of you guys took the ACLS class? Oh, you guys did? Okay, good. Okay, it's very funny. I went to ACLS class and same thing. They gave me the rhythm, and the guy was on cocaine or some sort, and then he got tachycardic, and then he said, well, that's another thing. When you're on cocaine or heroin or something, and you get tachycardic as a result of it, well, what are you going to do? And I'm like, well, okay, I'm going to go ahead and give adenosine, but before you give adenosine, I want you guys to remember this. Adenosine, what they do is that they completely stop your heart and they jumpstart your heart, right? So they completely stop your heart and then reset your SA node to go back to the sinus rhythm. So he said to me, well, the guy was sitting in the chair and said, I can't breathe, and blah, blah, blah. What would you do? I said, first I have to lay him down. Right? And then he said to me, you are not laying him down. I said, yes, I am, because he's going to fall flat on the floor if you don't lay him down, because remember, your heart will stop for at least 3 seconds. So if you're ever pushing that drug in a hospital, what do you think you should have at the bedside? You should have your crash cart. You should put the patient on the paddles, right? You should have it ready, because my very first time when I pushed adenosine, the same thing. I'm standing there, I push the medication with my nurse, and then the patient started rolling his eye back, and the monitor said, flat line, oh my God, you can see my nausea away. Even it's only 3 seconds, but I said to her, we should have had a crash cart next to the patient and the paddles on, That's what I would have, but yeah, adenosine is a pretty scary thing. So, okay. So we'll talk about the calcium channel blocker, right? We'll talk about DIT, beta blocker. Those are usually the medication that we use to treat the patient with the sinus tachycardia. Okay, let's look at this rhythm. First, what do we do first?
The rate.
The rate. So how's our rate? Let's see. 1, 2, 3, 4, 5. Does it look like 14 boxes instead of 15? Yep. What's the rate if we have 14 boxes?
107.
107 again.
Yeah.
Right. Can't be 107.
Yeah.
Divided by 14.
No, 14 small boxes.
Yeah.
Yeah, 107.
1,500 divided by 14.
Yeah.
It's 107.
Is that fast?
I think he just zoomed out since the last one.
No, I'm sorry. I'm sorry. It's, let's see, 1, 2, 3, 4, 5.
No, that makes sense.
It's not 14.
24 boxes.
That makes sense.
There's 5 little boxes.
Yeah, you're right.
That's
How many little boxes?
Is that 5?
20.
So it's 62.
no 62.
Yeah. Okay, that's more like it.
I was like, that doesn't look
It doesn't
that
look
fast.
like, it doesn't look like that.
Yeah,
60?
60 you by 300.
That's mine.
So
Mine.
it's like 60 something.
Okay, so it looks like in the 60s. Okay, so now it's an R to R, look regular, irregular.
Regular.
Look pretty regular, yeah? How about a P wave? Is there a P wave in front of the QRS?
Yes.
We do have a P wave. Are they all look the same?
Yes.
Yeah.
Right? They all look the same. So now the next thing we want to look at the PR interval, yeah? Is a PR interval more than one big box or smaller than one big box?
Bigger.
Definitely bigger, because if you look at this one, right here, to this one,
Yeah.
see, that's a big box, and it's almost like 2 boxes,
Yeah.
right? So if we look at this, we would say it's about 7 small boxes. So how long is that PR interval?
So small. What's that?
So,
0.28.
1.28, you know? So if all the PR interval look the same, they all about the same length, then what would you call that rhythm? First of all, are they coming from the SA node?
Yes.
Yes. So if from the SA node, what we call that? Sinus. Okay. Is it regular from R to R? Yes. So we call it regular. Sinus, regular. And now, because you have a prolonged PR interval, we call it
First degree.
first degree heart block. Right?
So sinus
Alright,
regular.
so like I said, first degree heart block, what do?
Watch.
We just watch. And we also want to do what?
Check if they have
them
beta
in,
blocker.
Right, to see if they have beta blocker. Very good. Now we look at this. Okay, first of all, let's look at our R to R. Is it regular or irregular?
Irregular.
Okay, you see this one here, and this one here. They're not regular at all, right? They are different distance, right? Now, is there a P in front of the QRS?
Mm-hmm.
Pretty good. All the P's are in front of the QRS, right? Now look at your P wave. Are they about the same? This one here, no, and longer, right? So they are a little bit longer and longer, and then right here somewhere, they should have a QRS,
Yeah, you lost.
and you lost your QRS. So remember, the PR longer, 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 and then drop the QRS.
Right.
Third degree.
Second degree.
Okay, first of all, is it from the SA node?
Yeah.
Yes.
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 So you have a P wave, right? So yes, that is from the SA node, so we call it sinus rhythm, right? Is it regular or irregular?
Irregular.
Definitely irregular, right? And is a PR long or short? Look pretty long. See, this is longer than one box, right? So they are, but the problem is they have longer, 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 and they drop. So that's why you know you're in a heart block somewhere. But is it the first degree or second degree?
Second degree.
Second degree heart block, type 1 or type 2?
Type 1.
Type 1. So, you see? Yes.
Is it just like the PVC considered?
No, we don't have any PVCs there. So we're not talking about PVCs right now. Okay? Does that make sense? Okay, do we treat this patient at all?
Only if systematic.
Only patient have symptom. What would you consider as a symptom?
No breathing.
Hmm?
He's not breathing.
Well, that's too bad. That is really bad. What would you consider as a symptom?
He has pallor,
Chest pain.
Huh?
pallor, he doesn't respond very well.
Okay, maybe change of level of consciousness.
Syncope.
Huh?
Syncope.
Syncope. Okay, that's pretty far back.
Yeah.
What would be the first thing, I mean, that when they come in the hospital, you hook them up to the monitor and say, oh, you know, you have
I
second
think so.
degree and type 1, and when should be the time that we should be treating this patient?
They say they have chest pain.
Chest pain or?
Chest pain
shortness
would
of
be
breath?
1, okay? You gotta think about chest pain. You gotta think about lightheaded. Why is it lightheaded?
They're not
Not enough
not an
oxygen.
effective pump. They're not getting blood to their
They're not
brain.
pumping. They're not getting blood up to their brain, right? Yeah, so that's when you start treating. Don't wait until they are parlor or stop breathing and that kind of long. But usually, these type of patients, that's what I would think about, checking their troponin. Okay, that when it causes dysrhythmias right there, right? Chest pain. Very good. Okay, now look at this. Is the R2R regular, irregular?
Irregular.
Regular.
No,
Looks
one
pretty
or two.
regular. A little bit,
I don't
yeah.
know. We need to
Yeah.
get calipers.
They look pretty regular. See? Right?
Calipers.
Right? Are they regular, irregular? They look pretty regular.
They look regular.
Okay,
Jesse,
now
you're doing
you
this.
want to look at your P wave. Is there a P wave followed with audit, QRS?
Yes.
Yes.
Say, before you say yes, look at twice.
One.
This is a P wave, this is a P wave, this is a P wave. I agree with you. But if you are measuring your P wave,
There's 2.
there's a P wave right there, there's a P wave right there.
It's not a U wave.
You guys see?
There's no.
And you say, well, how do I know that's a P wave? Remember, that's your ST, right? And then that's a P wave right there.
So then would it be irregular because they're supposed to be?
No, because
It
they're
doesn't
always
call irregular because if you measure the R to R, it's regular, but the thing is, they're missing a QRS.
There's missing a complex.
Remember, you have to see it's a P wave followed with every QRS. So this is a problem that, your P wave is there,
There's
but
just
there's
no
nothing
complex.
going down to, they're missing the link to go down to the QRS there, right? So that's why now you have
There's a
But there's
second
no
degree,
conduction.
type 2.
Two.
Right? Or, like I said, if you talk to the doctor, they probably
That's
said
what
2 to 1. So you have 2 P wave, 1 QRS. So, you talk to that person, you have to say it twice in order for that person to get a message. You have to say it twice.
So is that like the atrium is kind of like double firing?
Yes.
So it's,
Well, no, they fire it normally, but the message is not going through. There's a block somewhere that the message is not going through.
so
The atrium's fine,
so
but the
you got a
message
ventricle.
didn't get.
Gotcha.
There's nobody talking to the ventricle, or they talk to them every so often.
So the rate shouldn't be fast.
Their rate, if you're looking, if they are really firing, they should be faster. But they're not. You're right. And then if you see the PR interval is pretty prolonged too. They are rated in a box too.
So what's the full name of the column?
Okay, so is it sinus?
Yes.
Yes, because they have a P wave, right? It's sinus. Okay, is it regular?
Yes.
Because the R2R is pretty regular. Now, but the problem is that, they're not talking every single time, so that's what do we call it?
Second degree.
What we call it, that's a block, some sort of block, right?
Block.
But the block is that, like I said, because the AV dissociation, so that's why they call second degree type 2.
Two.
Right? So, do we treat this patient at all? Only if it's symptomatic, right? And my other thing is that, if you already took the ACLS, they would not recommend to treat you with the atropine. The reason is that, atropine also put you at risk with heart block. So when you have a high degree of heart block, you do not treat with atropine. The best way for you to do is pacing this patient.
Epi.
Okay.
Works with everything.
Does that make sense? Okay? And when do we treat these patients? What would be the symptom? What would be the common symptom?
Would it be similar, like the lightheadedness?
Lightheadedness,
Dizziness.
chest pain, or low blood pressure, right? That would be things that we would treat. Don't wait until they stop breathing. Now, let's look at this. What do you think? How many P waves do you see in between?
3.
2 or 3, they're all over, right? And it's a P wave.